And I am so glad that you guys, to be here for such a great event, and to be able to talk to you about one of the projects.
Are you going to stay here or are you going to be walking?
I could do either way.
Okay, just because this is for the camera.
Okay.
And this is for the house.
Okay.
So if you do decide to walk around, I'll need you to clip that onto your person. So
Onto my person?
Yeah.
Okay.
Yeah.
We'll stay right here.
Right.
This will be much easier. So the research update, I am really excited to talk to you guys about research. I think being in the CF community, as you all are, this is one area that we're so proud of, where we've come to this point and so proud of where we're going in the future. And I'd like to just spend about 45 minutes now going over where we've been and what we're going to. So the overview of today will review some of the pathophysiology of CF. We'll just spend a couple minutes, make sure we're all on the same page. We have a good idea in our mind's eye about what we're dealing with here, so we can understand some of the concepts that we're going to talk about with the drugs that everyone's asking about and the new things down the pipeline that we'll go over with today. I'd also like to spend a couple minutes on our historic gains in the CF care, just to talk about how we've gotten to the point where we've gotten and where we're heading for in the future. Innovations in CF management. We'll spend a couple minutes on gene therapy, because I think that's a question I hear a lot in the clinic, and so I just wanted to spend a couple minutes on just going over a little bit of the history and where we are in that venue. CFTR mutation classes. That's a hot topic, and that is really directing a lot of our current research, and so we'll cover that. And then recent drug study results. That's the question I think I hear at least once, if not twice, a clinic, is about what's going on in the new drug studies. And then I did reserve some time for questions at the end. I'm pretty informal. If you have a raging hot question that can't wait, please interrupt me, but I did save some time for questions at the end. So if once we get through everything, if there's any burning questions, I would be happy to review those. So pathophysiologic mechanisms of CF lung disease. We all know this. So it starts with a defect in CFTR. It leads us to defective ion transport, moves down to airway surface liquid depletion, defective mucociliary clearance, and that in itself will lead to the mucus obstruction and then this vicious cycle that we've all talked about. Infection, inflammation, more mucus obstruction, more inflammation, more infection. And so it takes what turns out in terms of being a pulmonologist, a CT that looks like this in terms of lung disease, pretty clear, just some small, does this have a laser on it, a pointer?
It does, the middle.
Oh no. The middle, oh, okay.
The round, big round.
The big round red button right there, got it, okay. The big round red button. So pretty normal looking lung tissue, just little areas of bronchiectasis, but doing pretty well, leading into advanced stage lung disease of the CF lung. So this is what we're trying to prevent. So it starts out pretty normal and moves to this area where we have secretions, inflammation, infection. So that's what it looks like from a picture standpoint, but I'm really more of a visual learner, and this is a video from one of the plenaries at the CF Foundation that I really think exemplifies what we're dealing with and lets us know, gives us a very good picture as to how this really works. So here we are, we're starting out in the back of the mouth. That's a little uvula right here. And we're gonna see if this works. Nope. Can I get this to work? I'm trying to play the video. It's embedded.
All right. So we have you. This is yours, right?
Yes, that's fine.
Let's see if we can pull this
So if you ever need a really nice video, the CF Foundation has created some great ones, and they're more than happy to share. And so this is one I actually use not infrequently. Should have had it on my person.
Yeah. All right. 1 second. All right. Do you have your video? Okay, so you have your videos loaded on here, correct?
Yeah.
Why it's not playing, I don't know. I think they're linked. Is it this?
Yeah, that's the video, but
That's the video.
it should be.
Yeah, I think what it is it's linked and there's way. Sometimes you can save it to it, and so it's a little weird thing, but we'll just play it directly off the media player.
All right.
Okay. It's just the way we're going to have to do it right now. Okay. So,
All right, here we go. So we are going down the airway. That was our vocal cords. Now we're passing. This is our vocal cords. Go into the mic, go on the mic. Down into the airway. So this is the main carina, and we're just going to dive right down into the tissue of the lungs. So what you're seeing is the surface of the lung is covered by lining cells, and they all have hair cells or cilia on top of them. And those cilia beat back and forth, and there's a kind of tiny layer of secretions that help to move. This is on the layer, and so these white things or yellow things here, those are actually the CFTR proteins, and they're moving chloride channels in and out and keeping that surface layer nice and smooth. So all the things that we inhale, the dust, the pollens, everything else, goes onto that surface layer, gets moved up, and we either swallow it or cough it out. So this is what happens in CF. So that CFTR, these channels don't function, so that chloride can't get out. And with that, this surface layer gets really condensed. So it's much stickier, isn't as fluid, it's not as moist, and everything that gets stuck there kind of starts to build up and up and up and up. And the hair cells can't function well anymore. And so the whole, when CFTR is not functioning at where it needs to be, you have a buildup of secretion that really leads to the changes in the airways that we're talking about. So if we can focus on CFTR, we can really fix the underlying problem. And where it resides, again, is in that top layer of those lining cells within the major airways.
do you have any other videos?
That was it.
Okay.
It's okay. We're good. Okay. So when I was talking to my aunt as a nurse, she's a retired nurse, she's about 80, and she lives afar, and so I saw her a couple weeks ago, and I said I was giving this talk, and she's like, "That's great, Michelle, that is wonderful. I did not realize that you worked in peds." And I said, no, I'm an adult only, I just do adults. And she was really taken aback. She's like, when I was practicing, this was a pediatric disorder. We didn't see adults. So she's like, you must not see that many adults. There can't be that many. I said, actually, about 50% of the population now is adults. So I have a lot of work that I'm doing. And she was really blown away because in her lifetime, she has seen a disease that when she was practicing in the 50s, 60s, 70s, and 80s, this was a diagnosis that it was a pediatric diagnosis. There was no adults out there, and definitely no adults thriving and doing great things in the community. So this really took her aback, and she was so impressed with that we have adult practitioners and that we're doing this. And I wanted to point this out. And so when we look at CF survival, it's increasing, and it's really going on a trajectory of great proportions. So back in the 50s, 60s, 70s, when my aunt was practicing, survival was in the 16-year, 18-year, 10 years in the 1960s. And last report, we're at about the 38-year mark. And so just leaps and bounds, we've been improving. And it's really due to a lot of factors. And so we're going to talk today about some of the new cool things, but I really want to focus on some of the everyday things and the out-of-the-box thinking that has really led to these strides before we had all these great new drugs, because there's really been some very hard work by a lot of people in this room and across the country that have really led to where we are in this field. So show of hands, does anyone know who this person is? Anyone? I don't have a Target gift card, but anyone? No? So this is Dr. Leroy Matthews. So he was a pediatrician in the 1950s in Cleveland Clinic. And in the late 1950s, someone came to him and said, his boss basically came to him and said, I think we should do a comprehensive CF program. And so he took that to say, let's build a program that is going to focus on all aspects of CF care, not just the lungs. He was a pediatric pulmonologist, but focus on nutrition, focus on monitoring for infections, on aggressive airway clearance, and most importantly, said we're going to focus on prevention. This was in a time when there wasn't a lot of drugs. Once people started to get those end-stage lungs and cough, that's when we started to act. He said, no, we're going to do it beforehand. We're going to do it before we develop anything. And that was a revolutionary idea back in the day. He really was a forward thinker. And he was so forward that he started reporting. And the other thing he did was actually said, I'm going to track this. I'm going to look to see what I'm doing to see if it's working or not. And so he tracked that. And when everyone else was reporting median survivals in the 5s, 3 5s, with annual mortalities in 20%, he said, mine's less than 1%. My kids lived to about 18. And everyone said, you're lying. And I said, no, I'm doing this whole program. He shared it with everyone. And it turns out this man found out that he was right, so he was reporting it. Does anyone know who this man is? No more Target gift cards. Sorry, guys. So this is Warren Warwick. Does anyone know who Warren Warwick is? So I'll give you the name. Emily's shaking her head. So Warren Warwick in the 1960s got a grant from the CF Foundation to actually look to see if Leroy Matthews was telling the truth, see what he was doing. Is he right? How is this happening? Everyone else is doing 20%, and you say you have less than 1%. So Warren Warwick got a grant, and he looked at all the available centers at the time to look at their data. He went there and he got it all, and he said, yep, Leroy is right. What he's doing is right. And it really revolutionized the practice of CF care. And it brought all the other centers, all the other doctors up to do the same things that Dr. Matthews was doing, and brought up the entire CF community to a level of getting, so that our survival was across the boards, wasn't just, 1 or 2 years of age. It was 15 or 16 in the 1960s across the board. What it also led to was the patient registry. And so these kind of early studies are said to have led to what we now know as a very robust patient registry, where we get data from almost, I think it's over 90% of CF patients in CF centers are within the registry. And that, as a clinician, is phenomenal. It gives us so much information to say, this is, every individual is every patient is an individual, and we treat them as such, but collectively knowing what's going on gives us so much more power, gives us so much more that we can really tell. And so Dr. Warwick, trying to assess Dr. Matthews, really came up with a great registry that's such a vital component to what we're doing. So even if you never participate in any research study, if you are just in our registry, we're so grateful because it gives us so much information that we can really lead to better care for everyone across the board. Does anyone know what Dr. Warwick also was notable for? It may be in some of your homes. The vest. Yes. So again, this is in the late 1980s. Before we had a lot of drugs, before we had all this other stuff, he said he took Dr. Matthews, we should do chest physiotherapy, but he actually made it accessible. So instead of requiring a caregiver to do a manual chest PT, he helped to develop a vest that can make it independent for patients and can really revolutionize how patients cared for themselves. So this was now something that you can go to college with, you can go and live on your own with, you don't need to have a care provider with you. And this is a clinician, this is a guy that takes care of kids during the day, but he's so moved by CF and getting our patients better that he really worked to get this. And so that's kind of where we led. So in terms of our history, we have innovations in CF management. And so we have our therapies that we like to think about, and here's kind of the timeline just to bring them to you. So there wasn't a lot going on in the 1960s and 70s. Again, really, that's when Dr. Matthews really was at his prime and was ahead of the game. He didn't have all these tools. He didn't have all these drugs. He really just had an out-of-the-box idea and saying, let's do this consistently, let's track it, let's do it early, let's have a very good idea. And fortunately, his patients and families were open to that and really embraced it. And I think that's a great part of the CF community, is that they embraced it and we saw the results of that. But there's been other drugs and other things that have come down the line to really help move the field forward and the management forward. And I've kind of listed those for you here. In addition, there's other activities that, again, we're all looking at the end game is getting people better, having them functional. Other activities, so looking at Pseudomonas, newborn screening, infection cohorting, those have all progressed over the course of time as our understanding through primary research has led us to change our practices. So the big issue that I get questions on are the pipeline. Everyone wants to know what's in the pipeline. And honestly, the CF Foundation does a great job of helping me keep track because there is so much work going on. The CF the NACF, the CF conference every year in the fall is wonderful. I look for new information every time, but there are 700 posters. I can't go to every plenary. I can't go to everything. I have to kind of pick and choose. So it's a great resource for me to know kind of where are we at with this. Things move at light speed. So this I will just refer to you. And I've actually shortened this down. I didn't even get all the pipeline things on there just so it fits on a screen so you can read it. But this is where you can find your information and really get a good idea of what these drugs are, where we're at, what's been the reportable findings, and to know what may be available very soon. Oh, Lord. Postpone in 4 hours. Okay. Here we go. Good. Good. I am not the tech savvy person. So the pipeline is great. The one question and I think what it had led to was in 1989, everyone remembers this, was that the gene for CF was identified, and it was a huge deal. This is the cover of Science magazine. This is the first time there was a human being on the cover of Science magazine, and it really was the big breakthrough. We found the culprit. We know what it is. Now we just need to figure out how to fix it. And there was a lot of energy, and there has been a lot of energy, thinking this is something that we can now correct. And there was a lot of intense effort looking into gene therapy. It was supposed to be the big thing that came out and found the cure and changed it. And the problem is, in a nutshell, it's just harder than it seems. So after 25 years, we haven't had a good response with gene therapy. There's been a lot of hiccups, a lot of issues that have been identified over time, and that's really just kind of where we stand in the field. Why is that? Kind of to just put it down there. So it's a difficult gene to deliver to cells. So it's large, and you have to put it into a package. So you have to get this huge thing and kind of put it in a small little container. And then you have to try to get it into the lung. And so we talked about, if you remember that video and the layer and there's all that stuff, these are all transmissible. They have to get to those cells underneath, through the mucus layer, into the cells, and then try to clear the immune system, because our immune system's still intact, and so it does a good job. So if it gets in there, it's going to try to clear it out. And then it has to actually get into the genome. Otherwise, it has to be reintroduced. And a lot of these vectors that have been used historically in gene therapy have been viruses. So getting influenza, cold viruses, adenoviruses. There's not a lot of CF patients that are like, sign me up, I'd like to get infused with the adenovirus. And because there's an immune response to it. And so that's part of the limitation. So when we talk about this, I just like to spend a couple minutes. This is where we're at. People are still working on it. But these are kind of some of the reasons that we haven't gotten there yet. So work does continue, but it's at a slower pace. If anyone's interested, Dr. Jane and I just wrote a review, and so you're welcome. I can send it to you. Kind of going over some of these topics, gene therapy as well as modulation. So if you want all the scientific detail in a review, I think we have a couple copies. Otherwise, I'm happy to send that out. So we know the problem. We know where it's at on the genome. We even know where it lives in the cell. Now we have to find out if we fix it. So if we can't fix it all, if we can't do gene therapy and get all the cells to have a normally functioning CFTR protein, how good is good enough is really the question. And so this is based on some natural history studies and looking at CFTR function. As well as the sweat chloride. So sweat chloride, as you all know, is kind of the pathognomonic test to diagnose CF. And so we look at it, and 60 is where we have the diagnostic cutoff. So if you're above 60, that's diagnostic for CF. And so we know if you have classic CF with 0 CFTR and a pancreatic insufficiency, you really have very low CFTR activity. It's really close to 0. If you have pancreatic sufficiency, it's usually thought to be lower on the spectrum. And then there's these atypical CF. And they have some decrease, but actually are doing okay, and they're just below the threshold. And then we have the carriers, and that's all, parents will have one CFTR gene, but they don't have any phenotype. And so it really gives us hope if we just have to fix one. We don't have to fix them both. We just really have to fix one. And if we fix one, there's no issues. And so this really leads us to a lot of good ideas. So we don't have to get into everything. We don't have to make it 100%. It's probably okay if we get it to about 50% or even 60%. which leads us to kind of this whole new thing. So I'm in clinic, and when I was young and growing up, a big question was, what's your sign, the horoscope, or your Taurus, or your Gemini, or your Sagittarius? Now it's literally, what's your genotype? So what's genotype? Do you know genotype? How's this going? Or what genotype are you? Do you know your genotype? This is always the question, and it's a good question. But it's something I think that we wanted to spend time on. And so there's these correctors, your corrector, your stop codon, or your potentiator, or your read-through inhibitor. So let's spend a little time going over what that is. So the CFTR mutations have been put into types or classes. And most people will talk about 5 classes. And so we'll start with, this is a normal cell. And you've got, the brains of the cell. It leads to protein synthesis, and that protein we talked about in the video it was yellow. Now it's purple, but it's popping out the chlorides through there, and so that's normal. And the different classes will break down, and it depends on which your mutation is. So there's a defective synthesis, and this is some of the X codons are the stop codons, and those are class 1. And so basically, there's a stop, and it says don't make any more protein before it really should stop working. And that's about 10%, and it really will lead to no protein. It stops it right off the bat. So up here, you don't see any proteins of the CFTR. That's class 1. Class 2 is where there is defective mutation in synthesis. It gets blocked on some level, and so it can make it all the way through the mRNA, but it gets degraded. And never gets to the surface. And that's really where the delta F508s come into play. And so that's the most common mutation, or class 2 mutations. And it's because there's just one thing wrong. It gets it out of the cell, but it gets eaten before it makes it to the membrane. Class 3s, that's G551D. They're blocked regulation. So they've got something up here. It just doesn't work very well. So they got the channel. It just doesn't function. And so that's a gating defect. So class 3s are the gating defect. And again, the G551D falls into that category. Class 4 is a conduction decrease. And this it's there, the chloride doesn't move as fast as it should. And so this is the R117H, is probably the best known of those mutations. And then class 5 is pretty low abundance. It's just a low abundance. It doesn't work with it. It's more of a milder gene. But those are the categories. So if you want to know what's your sign, what's your genotype, all of them will basically fall into this. And there's 1,500 gene defects that have been detected and been reported. However, most of them, again, most people will have a delta F508 as one of their genes. So going back to that class 1, what's that premature stop? And I hope you guys can see this, but this is how protein is made. So there's this little guy that runs along, and then it reads it until there's a big stop sign. So it reads through and makes it until there's a big stop sign. What happens in the class 1, there's a premature termination. So when it should say go, it says stop. And so it stops too early, and then it makes it too short, and it doesn't work. So the assist therapies that go for this, there's PTC-124, and that's part of the drugs in the pipeline. And what this drug does, actually, where it says stop from this mutation, it changes it to a yield or a yellow, and it lets it read it through all the way to the end to make the full-length protein. So instead of reading stop, it will read it to be more of a go. And it'll allow that protein to be made and get to the surface. So again, this is class 1. These are the stop mutations or read-through inhibitors. And PTC-124 is currently in the pipeline. So that's the one that you may hear about. And it's a smaller class, but it's definitely there. This is a good way, I think, to just break it down. When we talk about, because I get confused with, is it a potentiator, or is it a corrector? What am I? Am I a potentiator? So this is how I think about it. So we have the CFTR mutations, and there's a defect in the protein, and then it's really going to do one of two things. It's going to reduce the quantity at the cell surface, so delta 508 can't get to the cell surface, it's not there. Or if it gets there, it's not going to work very well. So even if you fix it, you get it to the area it's supposed to work at, it's not doing its job. And so this is kind of where some of these newer drugs, how they come into play. So the potentiators, this is G551D, this is VX770 or ivacaftor. This basically says it's there, but it's not working as well as it needs to be. And so it potentiates something that's already on the surface. It makes that channel work better. And again, ivacaftor, that's what it's doing. It's not going to be very helpful, though, if you give to someone who has delta F508, because they don't have things there. There's a paucity of those there. So for delta F508, you need a different type of drug, and that drug is also being evaluated. And so for L508, they're looking at a couple drugs. There's VX809, VX661, and they're looking at those in combination. So what they found in the early studies is even if you get it there, it needs some help. So even if you can get it to look like this, you need it to give it more help with a potentiator. You need to correct it, and then you need to potentiate it. And so, but that's the concept. Is everybody with me? Shaking? We're okay? So these are what these assist therapies are. So the ivacaftor, or VX770, it's an oral drug. It's taken twice a day, and it targets the gating defects. So it targets these class 3 mutations. It's the genotype G551D, which again it's very low prevalence worldwide, and it's about 4% of U.S. cases. And it's with the apical epithelium. It just doesn't open properly. And it's been shown to increase the probability of channel opening about 14 times from baseline in this particular patient population. So you can't give it to every patient. It's not going to work. But in this particular patient population, it works very, very, very well. And it takes something that looks like this and moves it to having normal functioning chlorine. So the one that works for delta F508 is called lumacaftor. Kind of makes sense. And the study name is VX809. That's the drug in trial. And that's the corrector for delta F508. It's for class 2. Its goal is to increase the number. So it's going to work to get that protein to the surface and to help to restore the function by getting it to the surface. The early trials that we talked about, just getting it there is not enough. It's not very robust response. So now they're combining it with a potentiator. And that's currently phase 3 trials are underway, which are combining the VX809, the corrector, with a potentiator that everyone has been talking about, with the hopes that in combination, this will correct it. So proof of concept, and I'm sure all of you are familiar with at least this drug, if not this study, because it's been all over the news, it's been all over everywhere, and I just think it's important to kind of review what it means and what our expectations can be for moving forward. So this is New England Journal of Medicine, and this is basically saying we can do this. We did it once, we're going to try to do it again. And here's our benchmark. So a little bit about clinical trials. This was a really well done clinical trial, and this is kind of how clinical trials are run. So you have a screening phase, so saying who has the right genotype, who has all the lung function in the setting that we wanted, who's in a certain category. And so there's a screening phase, there's a run-in, and then everyone's randomized. And this was a 1-to-1 randomization. So one person got placebo, one person got drug. And then they were taken through. Their primary analysis happened at 24 weeks. But the patients were followed out to 48 weeks. And at the end of the 48 weeks, so almost a year, they moved everyone over to this open label rollover. So at the end of the year, even if you got the placebo, you got moved to the open label rollover because they had such good results. So everyone who would participate in this trial at the end of the time actually ended up getting the drug until it came to market, which is really, really positive. And this is how the patients broke down. And again, the thing just to know is that there's placebo and there's drug, but everyone got evaluated. So we can really know, is this a drug worth taking? Is this a drug that works? And at the end of the time, at 48 weeks, there was a rollover so that everyone really got an opportunity until the FDA was able to make a determination, which ultimately did. And it did it because of this data. So their primary endpoint was change in FEV1. As you know, FEV1 is the lung function. And what they found was at 2 weeks, lung function increased about 10%. So that took someone who was at 70% lung function up to 80% lung function within 2 weeks. We've never seen that before, at least not to that robust. And more importantly, they stayed there. So through 48 weeks, they stayed at that level. And as you would imagine for placebo, again, placebo's still getting every other CF therapy we have out there. They weren't just left to have nothing. They were on every great CF therapy we have, but this was on top of that. We also saw a huge change in weight. So, and and it increased at 48 weeks as well. People were putting on an average of 3.5 kilos. That's about 10 pounds. Then they also looked at event-free event-free time. So events being hospital admissions, severe exacerbations, and what it found was that the patients on the ivacaftor had a significant improvement in their a limitation of events. They did not have as many events as patients that were not on the ivacaftor. But this is what impressed me most and impressed most of us the most. And this is, from what I understand, kind of an afterthought about doing it in this trial. They looked at sweat chloride. We talked about sweat chloride as really the pathognomonic change, the diagnostic change in CF. And what they found was with patients with placebo, they all stayed at about 100. So clearly in the realm of cystic fibrosis diagnostically from a sweat chloride. Within 2 weeks, they were below the threshold level. And it continued out to 48 weeks. So this took a patient who had diagnostic levels of CF, or by sweat chloride, to atypical at best. And again, we have not seen this ever in the CF community that I'm aware of. And it really lets us know this is something we can do. This is something, if we can't do gene therapy, can't replace, we can bring this down to functionally normal functioning, normal phenotypic lung tissue. So here's the problem. So only 4% of the population in the US has G551D. So it really brings up, this is the tip of the iceberg. We can do this, but it's really in a very small subset of patients. Because the vast majority will have a delta F508 mutation. So about 90% of patients in the US will have one delta F508 mutation, and about 50% will be homozygotes, will have two. And so this is the studies that are underway. This is the big prize. This is what, if we can fix this, this is what we're really going for. And those studies are currently in process. So I have a little bit of data, but the data for that is not been released that I'm aware of. But we'll talk about the preliminary data. So this is a phase 2 of VX-809 plus ivacaftor. And this is in delta F508 homozygotes. So what they've reported, and again, this is on the pipeline website. All of the things that have been reported are on the pipeline website. There's been an increase in FEV1 in patients receiving ivacaftor plus 809, or lumacaftor, compared to placebo in people with 2 copies of the gene. So the treatment effect is about 8% in the higher doses. So this is phase 2, so it was a dose study. So they started at low doses, higher doses, and they found it in the highest dose is where they had the biggest response. About 55% of these patients had greater than 5% increase, and about 25% had a greater than 10% increase. So there was definitely a very good response with the highest dose in this study. What about the patients with only one mutation? They had a response, but it wasn't as robust. So they're working on that, they're looking on that, but that's just the information that we have. Adverse events, there have been pretty few, and they've been mild. And that's part of what phase 1 and phase 2 studies are looking at. What are the adverse events? So really the big meat of it is the phase 3 studies, and those are currently underway. I don't have data for that, but they're in the process. We're seeing those patients, we're getting them drug, we're getting looked at, and we're in the process of getting that information. And when it's out, you all will be the first to know. But it's in the phase 3 are looking at the highest dose that they found from phase 2, and they're moving it forward in big groups to move through to see if it works and to get it through FDA approval. So it brings us back to the pipeline. And again, if there's any questions, this is the place to go. This is where I go, this is where I look to see what's out there. And there's a bunch. We've talked about a couple of them today. PTC 124, there's Kalydeco, there's an N6022, which is a new anti-inflammatory that works with CFTR as well. Plus all the drugs to restore airway surface liquid, and a bunch of anti-infectives that I didn't cover today, but they're out there. They're being looked at, and they're in different phases. So if you're looking to see what's out there, this is a great place to start. And if you have questions about where these trials are available, I think the CF Foundation or your local chapter can help direct you to who has these charts. And with that, I like to stop with a question. And I give this when I talk to the medical students. I show them this picture. And I ask them, they have clickers and it's all very high tech. But for here, we'll have a show of hands. So which photos does not contain a person with CF? Who thinks A? No one thinks A. B? B? Okay. C? D? D. Okay. Who didn't vote? Most of you? Okay. Why did you say D?
Because I think you're trying to pick a
You guys are so savvy. You're just like my patients. So the answer is D. And I thought you were going to say because this kid looks like me, and that's because these are my kids. So yeah, but you're absolutely right. Most of when I give this talk to med students, they all say it's the single adult. That's the one that they usually pick. Some will pick my kids because they can figure out these look like me. But I use this because this is it's a very important thing to have in our mind's eye what CF patients look like, what the patients I see on a weekly, daily basis, what they look like. And they look like you and me. And these guys really look like me. And these are all patients from our Faces of a Cure. So a couple of years back, our research coordinators were really trying to bring forward the benefits of research in the CF community to say, this is what we're doing. These are the people doing these studies. And so these are our patients that all kindly gave of themselves and gave images from their families. So we can put these up, and they were up in our clinics. And we show them not just to the pediatric side, but to the adult side, the young adults, saying, this is the face of CF. These guys are doing research. They're leading active lives. And what I always point out with this is whenever you see a parent and a child in any of these pictures, it is not the child that has CF, it's actually the parent. And I think that's so important because these are parents like you, me, and everybody else. They are working jobs, they're doing everything they're doing, plus they're managing CF, plus they're working to find a cure for this disease. And it just is so very important for us to have that picture, to know they're out there, to know this is the possibility, because really hope is what we're all here for. This is what I'm here for, it's what you're here for. And this really tells me, it brings me hope. These are the images of hope to me. And so when I think about, when we did this, we actually found that we had a really good improvement in enrollment. People wanted to do drug studies if they could. But what it tells me is, thinking back to my aunt, in her lifetime, she saw CF go from an infant disease to an adult disease. In my lifetime, I'd really love to see this go from a adult disease to, well, we used to have to deal with CF. I remember that. So with that, I thank you all for your time. I thank you for giving yourself to come today, for doing the registry, for asking questions and being a very good advocate for patients, and letting us think outside the box and move this work forward. So with that, thank you, and I will take any questions.
So for the phase 3 trials that are underway for Delta 508 population, that's being done in adults right now?
The phase 3 trials is being done in adults, I believe.
So if it's approved for adults, how long does it usually take for a drug to get approved on a pediatric level? And if your child's under like the 6th range, can you get it off label, or how does that typically work?
Oh, you're talking to the adult physician here. Okay. Eileen, can you answer this? No.
I think it's 12 and up.
I think it's
The
12 and up
current
because it's
trial
at our
with
children.
kids,
Yes.
yeah.
So 809 is 12 and up. 661, which is the second reiteration of the Vertex corrector, is adult only. That's 18 and up. But I think 809 is 12 and up, and that is really close to the end, from my understanding. So it's an issue with the FDA getting things, once it's approved, there's an approval process. They're actually working with the foundation. They worked with the foundation for 770. It got through within months, which is revolutionary. And I know they're working with the foundation to move it forward as fast as possible. And then I think getting it to the younger populations, because really, if you ask me, I think that's where, if you go back to the preventative Dr. Matthews approach, I think that's really where it's going to be most helpful.
So when you showed the picture of the like mucus getting clogged up and whatever, so the high dose is working really well. Do you think that it's something where, like, once the high dose is in for a while, things get cleaned up, maybe the dose can be dropped after time?
We don't know. And that's kind of the issue. And so part of these studies, and that's why they have the extended phase, is we don't know how long is long enough, when you can back off. And we're using it, again, the phase 3 studies are mostly started in older populations. So it's people that have already had some evidence of some lung disease for the most part. That's the inclusion criteria. You can't be too well or else they won't find a response. And so they want you kind of in that middle ground. And so I think the big question is what happens if you use it in someone who really doesn't have any underlying evidence of lung changes? And I think that's a great question. And when can you, do they need such high of a dose? We don't know. At this point, the goal is really to look at, let's get these drugs available. Let's look at it in a safe manner. And so they don't always look at really little kids. They start with adults usually and they move it down. I think you're right, it is 12. But then they start, I know that the 661 they're looking at in 6-year-olds. So they have moved that to, there's a study looking at it in 6 and up. And kind of answering those questions. But we don't know from those initial phase studies. They will probably most likely be additional studies to get more information as we move down the line. There's a question over here.
For Kalydeco, the weight gain, do they think that's because they're fighting less respiratory infections, the body's better able to gain weight, or do they think that's because the drug is having an impact on the pancreas?
That's a great question too. You guys ask great questions. You guys are always great. We're not 100% sure. This is a systemic drug, so it comes in an oral tablet, so it should be expressed in any organ that has CFTR. Typically, the thinking is with pancreatic insufficiency, it's because the ducts that get blocked, that they don't work, and then they kind of just fizzle out. And so you're on pancreatic medication replacement long term. And we're not seeing in our patients that are on ivacaftor that they can come off their enzymes. So I really think it's more of the former than the latter, that they're having improvement in their infection in the lungs, because we know that weight correlates with lung function. So as you improve your lung function, your weight should go up and vice versa. But I think it's more from that just because of a lot of factors, and we haven't really seen any patient come off of their enzymes to this point.
Do you know if there are any plans in the works to study Kalydeco with patients who have only one gain mutation?
There's another studies in the works looking at different gating mutations, yes. That is the talk that they're going to be looking, so not just G551G, but in that same class of gating, the class 3, yes.
But homozygotes for a different gating mutation, or could they be having?
Very rarely will you see, because Delta F508 is so prevalent, it's 90% will have one, if not two, that it would be rare to have two class 3 mutations. It's not to say it doesn't happen, but it would be hard to do that study because there's so few patients that we know of. And we know of, with the MAP program through the foundation, we're able to genotype just about all of our patients now. And it's a rare incidence that you're going to have two gating mutations.
No, I was, let's say, one Delta F508 and one gating mutation that's not 5.
They were looking at that for the phase 2 studies, and I don't know the answers, but that was part of the 809 studies. They had different cohorts, and I think they were up to 7 cohorts the last time I heard. But they were looking at homozygotes, heterozygotes with this mutation, heterozygotes without that kind of mutation. And they didn't want to have, and then trying to figure out how important that is, how big of a factor that is into play. So they have looked at it. I have not seen any of the data available.
So is there any kind of treatments to help with the pancreas? Like, so you're not taking your enzymes, like how Kalydeco is helping with lung function? Is there anything coming down the pipeline with that?
Not that I'm aware of. No, I know that the big questions are looking at safety of enzymes and looking at to make sure that there's no issues with fibrosing colonopathies and other things like that. But I'm not aware of any. At least you can check the pipeline. I focused on the one of the questions I think I was going to have. I'm not aware of it though. Not to say that there couldn't be any down the line. Most of these also are systemic drugs that they're looking at. So it's going to be something that goes to all the cells in the body, not just the lungs, not just one area. So it may have some augmentation, but I'm not familiar with any specific studies right now.
So you mentioned that the results of the combo were less profound for patients with only one copy of the Delta F508. What is being done to kind of increase efficacy or to help those heterozygous patients?
I think that the research is early, and again, that hasn't even been reported it's been a press release from that information. It has not come even out into a journal or a scientific journal to know. I don't even know what the absolute data looks like. So when they were building these studies, they actually built them with the design of getting them to market as fast as possible, based on the success with Kaleido. So part of the strategy for all of this, from my understanding, is they want to have the best outcome, to have the broadest indication, so that the drug can be available to all patients as quickly as possible. So I don't know the absolute data other than what, again, that's from a press release. It hasn't been formally reported, so I can just tell you what is out there in the stratosphere. But I'm not sure what the data looks like, and I'm not sure what the next step is going to be. But that's really the rationale. So it's not to say that we're not going to do anything with heterozygotes, but I think the focus right now is getting the drug to market that will have the biggest impact across the boards, and then looking at other things. Again, they started with something that was 4% of the population. Now we're trying to expand it. So it's not to say that it's not going to be on the docket, but it's trying to get that drug out to the biggest proportion and then move it from there.
Is the foundation still supporting, and this might not be the right question for you, but are they still supporting people getting tested for their mutation? Do they know what they have? I know there was some.
I believe so. It was called a MAP program through the foundation. So I believe it's still going. At least it was a month or two ago. But it was a mutation analysis program. And so any patient that had not been tested, and again, this was mostly adult populations, because they would get diagnosed 30 years ago before we really knew what the gene was. So we've been able to go through and get most of our patients tested that way. A lot of younger patients, I think, has been more along the lines of, in their workup, they will have the genome assessment, but I believe it's still available for pediatrics. But the idea is to actually get every patient genotyped, and I believe it is still ongoing. That's it. Well, thank you so much for your time and attention.